Very pleased to welcome back Dr. Christopher Resnik. Chris is a prosthodontist in private practice in Winter Park, Florida. He received his dental degree as well as his specialty training at the University of Pittsburgh. And he's on the faculty of the Resnik Institute, which is the preeminent implant training group in the United States. And today he's going to continue his discussion of restorative options, presenting the options for full arch implant restorations. Chris, it's all yours. Take it away.
Thank you, Dr. Park, and thank you to the panel, as always, for some outstanding insight there. So this morning/afternoon, we're going to be going over the restorative options for full arch implant restorations. So we'll dive right into it here. Now, so our learning objectives for this webinar here is we're going to go through different prosthetic options for treating patients for full arch treatment. We're going to go through the advantages and disadvantages of both fixed implant restorations as well as removable implant restorations. And then lastly, we will go through the restorative space guidelines for these specific implant restorations. If we first start and look at kind of full arch implant patients and look at our patient base, there's three different kind of categories that we're going to have walk into the practice desiring treatment. The first patient is going to be an edentulous patient. This is going to be a patient that could have been just edentulated, or they could have been in a denture for 10, 15 years. We're then going to have our terminal dentition patient. This is going to be a patient that comes in off the street that's neglected their dentition for several years, and there's nothing we can do with them. So the only option is to edentulate them. And then there's a third category that's somewhat of a gray area and hot topic recently in the news, and that's going to be the questionable dentition patient, where their dentition could be saved or there is some treatment to do with their dentition. However, there's also the option to edentulate them and look at implants there. If we first look at our edentulous patient, again, this is a patient that could have been just edentulated. It could be a patient that brings their paper bag of 14 sets of dentures, and they want you to make the 15th set because it's going to be the one that works. And if we look at giving them an implant restoration, whether it's a removable or fixed implant restoration, there's many advantages to utilizing implants. If we look at the literature, we're going to have increased chewing efficiency, whether it's removable or fixed, increased quality of life, less bone loss. The studies actually show that creating an implant restoration will prevent future bone loss, where, as we know with dentures, over time their soft tissue wears, as well as their bone needing the relines. Increased biting force exponentially, just from going to a 2-implant overdenture compared to a denture. They're getting 2, 3, 4 times the biting force that they had with their conventional prosthesis, and the longevity of their prosthetics will be much, much better than a conventional denture. If we look at the prevalence for edentulism, this is kind of an interesting statistic here, where the percentage of population of edentulous patients is actually decreasing. So if we look at this study here in 2012, about 16% of the patients are edentulous. In 2020, about 13%. But interesting enough, the number of edentulous patients is increasing. So patients are living longer, the baby boomers. So even though the percentage of edentulism is decreasing, the number of edentulous patients that we're seeing in practice is increasing. This is a study by the U.S. Department here that found that over the next 5 years, about a 6.5% increase in edentulous patients. So there's many patients out there that we can treat with full arch implant restorations. Our next patient base is going to be the terminal dentition. This is the patient that's neglected their dentition for many, many years, and there's really nothing we can do with it. So the only treatment option is to take them out and then present them options to rehabilitate them with conventional removable prosthetics or implant prosthetics. If we look at the advantages and benefits of giving them implants, whether fixed or removable, ultimately we're helping their general health, helping their oral health, restoring function to what they did not have when they had their terminal dentition, and ultimately giving them aesthetics. Even if it's just a conventional denture, it's going to be much better than that image on the left there, where it's just a neglected dentition. And then the last is going to be a questionable dentition. And this is a somewhat of a hot topic right now through the news, where we have a patient that um, comes in with dentition, and for some reason they don't like their dentition. You may be able to save it with crowns, conventional partial dentures, bridges, but they're seeking, the all-on-4 treatment, all-on-X treatment. They've seen the news. They're done with their teeth. They don't want to take care of their teeth. They want their implants. And there's somewhat of a drawback for this type of patient that we do need to relay to them before we just jump into treatment. One is implants are not natural teeth. There's no proprioception with implants. So when they get their implant restoration, it's going to feel and function much differently than it did when they had natural teeth. The aesthetics, yes, it may be an improvement, but it may also be a step back there. We're usually using artificial gingiva, whether it's an overdenture or fixed prosthesis that patients may not be aware of. We then have the ethical dilemma here, which most recently CBS News just put a article out there, which I'll show on the next slide here, highlighting the ethics of dentists with full arch implant restorations. And then ultimately the complications, which we will go over shortly here, but there are inherent complications with implant prosthetics that patients must be aware of, and you must be aware of if you're treating these patients with implants. This is the kind of alarming study that came out about a month ago here, or 2 or 3 weeks ago here with CBS News. And you can just look at the headline there. Dentists pulling healthy and treatable teeth to profit from implants. Experts warn. So this is a pretty alarming article out there, which goes through a couple patient examples where patients went in, they didn't like their teeth anymore. They thought, the all-on-X treatment was going to be the best thing for them. They got the all-on-X treatment, and then their kind of life unraveled, where it just wasn't what they were expecting. They weren't aware of the risks and kind of what they were getting. They woke up from anesthesia and they just weren't happy there. So it's a pretty alarming study that now people are going after dentists that do this treatment, which some may say may not have been needed, where we could have done conventional dentistry, whether it's veneers, crowns, bridges, partial dentures. So we do have to give the patients all options. And I'll go through that with our treatment planning, with it, the importance to give patients all options there. So if we kind of summarize our patient base that we're going to be dealing with these full arch implant restorations, we have our edentulous patients, terminal dentition, and questionable dentition. And ultimately, the way the patient presents is going to kind of help us with what we're going to be giving that patient. For example, an edentulous patient's already used to taking something in and out of the mouth there. So they may be a good candidate for an implant overdenture, where somebody that has fixed dentition may struggle with taking something in and out of the mouth there. But ultimately, our job as dentists and clinicians is to make the patients fully informed of their options and benefits of every treatment. So we shouldn't be just giving the patient one treatment. This is your only option. Take your teeth out, get implants, all on X. We should give them all available treatment, explain the advantages and disadvantages of each treatment modality there. So if we look at full arch treatment options, we're dealing with patients that are going to be edentulated or already edentulous. And as clinicians, as dentists, we can't be like an assembly line. We shouldn't be a robot where every single patient that comes in that door is getting 2 implants and an overdenture. Or every patient that comes in is getting 4 implants with the 2 distal ones angled for an all-on-4 prosthesis. We must cater our treatment to each patient independently there. So one size does not fit all, especially with full arch treatment options. Even if one treatment may be best for the patient, it's our job as clinicians to present each available treatment option and let that patient make an informed decision on which way to proceed. There are complications if we do just treat each patient with the same treatment. So if we look at the literature, there are a lot of good studies out there looking at complications with implant full arch restorations. This is a great study out of Loma Linda here that looked at full arch fixed implant restorations, 9 to 15-year follow-up. 65% of the prosthetics had at least one complication throughout that time frame. Biological complications, about half of them. Technical complications, 43%. So that's a very high complication rate that, if a patient comes in and thinks that they're getting all their teeth out, they're going to get that all-on-X prosthesis, and then they never have to see the dentist again, they're wrong. In fact, they actually have to see the dentist more frequently after they get their all-on-X prosthesis than somebody that has their natural dentition. I put two cases in here that I actually saw this week. This is a case I saw on Monday. This is a all on X case that I did probably about 6 years ago, and the guy just left and never came back for maintenance. And then he calls me um, Monday morning and says his prosthesis came out. So this is a all on X prosthesis here where he fractured one of the multi-units off, broken screw in the one next to it, and then the other three had a debonded tie base. So that was a interesting day at the office appointment for this patient to try to get him back to having teeth in the mouth. And then this was another one. This is a consult that I did where the patient had upper and lower all on X treatment completed out in Miami. And he came to me for a second evaluation. And you could see just from that table there, he has a stack of papers. He did his research online. And then where I have that arrow, that's his upper fixed prosthesis that's currently on the table there. So they made it cement retained, and the cement they used never was able to hold the prosthesis in. So he sits there and uses Fixodent to fixate it in the mouth there. So you can understand this guy is not happy because he thought he was getting fixed dentition and his upper do not stay in. So they constantly come out there, and you can just see from that stack of papers the nightmare this case is. So there are complications that you must be aware of with these full arch restorations. And then this is a very good article by Good Acres Group looking at implant overdentures. So a removable implant prosthesis here, looking at some of the more common complications, loosening of the retention mechanism, so worn out locators, O-rings, implant loss, specifically in the maxilla, where we have the highest failure rate is with a maxillary implant overdenture, and then we have relines and attachment fractures there. So many complications that we must be aware of with it there. So with those complications and dealing with these full arch treatment, full arch patients that are going to be edentulous or already edentulous, we must present them all options, go through the advantages and disadvantages. And these are kind of the four options that I give every patient that comes in. One's going to be no treatment, where they can continue at their current status. Second is going to be a complete denture. We then have our implant overdenture and then our fixed prosthesis. And what I use is a organized treatment planning approach. So I do present each patient with those four options, but I also go through the advantages and disadvantages of each one. And I look at many factors when I'm dealing with these patients here. So we're going to go through these, but we're going to look at the bone quality, the quantity. Do they have enough bone for enough implants for a fixed prosthesis? What is the patient's goals, their expectations, their aesthetic demands, finances? What is the opposing dentition or their current dentition? Pair function, do they have it? Is it present? The restorative space, and then their dexterity, hygiene, health history. This is all going to impact the ultimate decision for the patient as to what treatment we are going to move forward with. So if we first look at the bone quality and quantity, we have patients of all realms here. So patients with great bone quality and quantity, and then we have patients with poor bone quality and quantity. That's ultimately going to dictate where we can get implants. Do we need bone augmentation? Do we need to do sinus lifts, GBRs to create bone to put the implants in the correct location? But this is ultimately going to dictate the number of implants that we're going to place, where the implants are going to go in, and the ultimate restoration. This is something that not many people look at, that we stress a lot in our surgical and prosthetic continuum here, but is the arch form. Not only the arch form of the patient's alveolar ridge, but also where the teeth need to be. Being a prosthodontist, you always have to kind of consider where that patient's teeth need to be. And the importance of this is with where those anterior teeth need to be. If it's off the anterior of the alveolar ridge, you have what's called a cantilever there. So you have kind of a diving board effect there. So if you have teeth that need to be offset off the anterior ridge there, so a patient that has had been in a denture for 20 years, or has had combination syndrome and just lost that anterior maxilla, you're going to have a large cantilever in the anterior. So it's going to be advantageous to get another implant in the anterior, which is ultimately going to dictate our treatment planning and our restoration. Patient expectations and desires. you see a lot of ads there on TV where patients get the all-in-X treatment and, they're sending them to the steakhouse that day to go eat a steak. Or, if just we'll give you an implant overdenture and you can eat anything you want. There's ultimately things patients can and cannot do with implant restoration. So I think it's very unrealistic for any denture or overdenture patient to be able to eat an apple. So I don't think you should be making promises that, yes, Mrs. Smith, you're going to eat whatever you want with your implant overdenture. I like to kind of make it worst case scenario for them. And if they can't eat an apple, then you see them like a hero at the end of the day. But you don't want to tell that patient, we can put 3 implants in, make you an implant overdenture, and you're going to eat whatever you want, because that patient's going to come back in 2 weeks and say, you told me I can eat whatever I want. Now I can't eat lettuce. I can't eat an apple, because then you're on the defense there. So I like to kind of scare patients where, implants are great, but you're not going to be able to eat what you do like with your natural teeth currently there. And ultimately, our prosthetic um, planning options is going to be driven by that patient's restorative demand. So we'll use that. Aesthetics. This is something very big here, especially with edentulous patients. Whether or not they've been edentulous for many years, they generally will have that sunken in soft tissue profile. And then we also are evaluating their smile line. So the smile line and lip support. The high smile line is something that we need to be very aware of, especially entering full arch implant treatment here. About 10% of patients do have this high smile line where they do show the gingiva. Reason that that's so important here is because that's called the transition line, or prosthesis tissue junction. So when we're giving a patient a fixed implant rehabilitation, a lot of times we're going to be making what's called an FP3 prosthesis, where we have artificial gingiva on that prosthesis. And if that patient smiles with their high smile line and they show their natural gingiva and the artificial gingiva, they're going to see that junction there and it's going to look terrible. So a lot of times we're having to do significant alveoplasty to hide that transition line before placing the implant. So this is something we must be aware of before entering this full arch treatment. And these are the complications that can arise here, where that patient smiles and they show the artificial pink and they show the implant platform. That is just a bad day at the office. When that patient comes in, you don't want them in the waiting room when they're smiling, because everybody's going to look like, what happened to me here with that. So two techniques that I've used throughout the years that work very well is in relaying this transition line or that smile line to your surgical plan. Is one is to use gutta percha. The second is to use lead tape. So if somebody has a very high smile line, what I'll do is I'll make them an Essex, or if they have a denture, I'll just put the gutta percha or lead tape on their denture. And then when you take their CT scan, you'll see that radio opaque bead going all the way around. So what that's going to do is, when you're planning your case on the CBCT planning software, you're going to place the implants below that line there. So you're going to make sure that you submerge those implants below their highest smile line there. So that's a little tip that's worked well for me over the years, because it's very important to make sure that you do enough alveoplasty on these cases to hide that transition line. And next, we're going to look at the soft tissue support. So patients that have a collapsed bite, collapsed vertical dimension, or have been in a denture for many years are going to have that kind of sunken in approach there, where they may not be a good candidate for a fixed prosthesis. They may need that flange of a removable overdenture here. So we're going to evaluate these patients before we put the implants in to see, you know, we're going to need that flange and that prosthesis. So you're not going to be a candidate for a fixed prosthesis. We need to be able to bulk out that your lip profile there with a removable overdenture. And then it also works where if somebody has a very full upper lip already, we may need to do some alveolar recontouring with our implant prosthesis to create some room for a removable prosthesis. So we're going to look at the lip support to help us dictate if we need bone reduction or if we do need a flange or flangeless prosthesis for the patient. The opposing and current dentition, I think this is a very important evaluation tool when planning these cases. If somebody comes in with partial dentures or already have conventional dentures, they are generally going to do better with a removable overdenture than somebody that comes in with fixed dentition. If somebody comes in with fixed dentition, let's say they're 75 years old, they've never had anything that comes in and out of the mouth, they're going to struggle a lot more getting acclimated to taking something in and out of the mouth than somebody that's had a partial for 30, 40 years there. So this is something that it is important to kind of evaluate and also discuss with the patient. So if the patient chooses to go ahead with an implant overdenture, they must be aware that that prosthesis is going to come in and out of the mouth every single night. And generally, you're going to put it in a glass of water and let those gums breathe there. Where a fixed prosthesis, the patient's not going to be removing it. You're going to be removing it as the dentist there. Restorative space, we'll cover this at the very end, but ultimately our implant prosthesis is going to dictate the amount of space that that restoration is going to need and where those implants need to be. Our bar overdenture is going to be much different than an FP1 fixed prosthesis. Parafunctional habits. Does the patient have parafunction? Did they come in with loss of vertical dimension? They've worn down all their teeth to the gingiva. Do they have hypermasseters there? These are going to be patients that we're going to have to over engineer, not so much as that pan on the bottom right there where the patient needs 32 implants, but they may not be a good patient candidate for a 2 implant overdenture. We may need to make them a 6 implant overdenture, or all on 4 may not be the best case for them. Maybe we need to look at doing 6, 8 implants for them, but we must treat each patient independently. Not every patient needs 4 implants for a fixed prosthesis. A lot of patients need 5, 6, 7, 8 implants to be able to deliver them a fixed prosthesis. And then lastly, the dexterity, hygiene, and health history. So is that patient able to clean underneath that fixed prosthesis? Are they going to be able to get kind of the proxy brush in there or a water pick to clean it, all those difficult spaces? Do they have the dexterity to take out an implant overdenture? And then a lot of patients are on medications, especially the elderly there. Do they have xerostomia? If they have xerostomia, they're not going to really do well with a conventional overdenture with it that's resting on the soft tissue. So these are going to be things that we're going to have to evaluate with our treatment planning of these patients. And then lastly, ultimately, the finances. So what does that patient, what are they capable of affording there? So not all patients are going to be able to come in and afford that full arch fixed prosthesis. They may be just a 2 implant on a lower overdenture and upper denture. So this is something that we must also discuss with patients. So ultimately, we have many different treatment modalities for these patients. So which treatment is best for the patient? And with all those different things that we evaluate those patients for, I use an organized treatment plan approach. This is a treatment planning form that I give all patients. I actually email it to them. My father created it many, many years ago, and we've been giving it to everybody at the Institute for many years here. But this is a organized treatment planning approach that I give to every patient that is a dentist, has terminal dentition, or is thinking about taking out all their teeth. And it goes through each options. It has the advantage and disadvantage of each treatment. And then it also has the phases of treatment. So how long it's going to take that patient to complete an all NX treatment. We have different phases, the immediate implant placement, immediate loading, and then also the final implant restoration. Similarly with implant overdentures, we have different phases of treatment. So it goes through each of that as well as the cost of it. And this can be accessed on our Institute website. We have at the very top there where the publications are, there's a forms tab where it has a treatment planning template as well as the advantage and disadvantage of each treatment there. So you're able to download that and utilize it in practice with it. So it'll come in a Word document there. So if you want to download that after this webinar, I highly recommend using it to give to patients here. So if we go through these treatment options, the first treatment option on that template is no treatment. This is something that I give to every patient, whether or not I'm doing a single implant at number 8 or we're doing a full arch treatment option. And we kind of use this no treatment option as an advantage to incline the patient into treatment there. So what's the advantage of no treatment? Well, you don't have to do anything. You don't have to come back to see us. You can continue using your worn down dentures with your adhesive, or you can continue, chewing with your mixed dentition and those edentulous patients. Disadvantages, you're going to have continued difficulty with whatever brought you in. You're not going to have the teeth that you wanted to smile with, but you don't have to see us again. So I'm going to use that as kind of an advantage to push the patient into treatment here. The next option is going to be our complete denture. So, advantages of complete denture, they're fast, cheap, no surgery or no or minimal surgery. It takes what, 4 or 5 visits, and we can get them done in a month here. So, however, there's many disadvantages. Removable prosthesis, difficulty in eating and speaking. So there's a very large learning curve to utilizing these removable prosthetics. Issues with retention. So upper dentures work well on about 8-9% of 9 out of 10 patients. Lower over dentures don't work really on anybody. So explain that to a patient. We can make you a lower denture, but it's not really going to do much other than, hold that aesthetic value. The upper is going to have the palate covered. So you're going to have lack of taste, and you may have to use adhesive with these dentures here. So this is a option that we must present these patients. But as you can see, there's a laundry list of disadvantages of them. And then we get into our implant-based treatment modalities. The reason that kind of we're putting this presentation together. So we have two basic avenues. We have our removable overdentures, and then we have our fixed prosthesis, or all on X. Ultimately, this is going to be dependent on the bone quality and quantity, but we're going to present this option to all patients here. If we look at removable implant overdentures, all overdentures are not the same. That's kind of the biggest thing to take away with these is a one implant overdenture is going to be much different than a bar supported overdenture, or 2 implants on the maxilla should not be treated the same as 6 implants on the maxilla. Each overdenture is going to be different with it. And in doing so, we must understand the biomechanics behind overdentures. So there's 3 kind of basic principles here. One is going to be the type of attachment. So we have 2 different categories of attachments that we can use with removable overdentures. One is going to be resilient, and the next is going to be non-resilient. If we look at what that means, resiliency with overdenture attachments means that there's going to be some movement of the denture onto the soft tissue. So the attachment that we're going to be using, or our resilient attachments, are going to allow some movement around that implant onto the soft tissue. So we're going to be utilizing the implants as well as the soft tissue to help support that denture. We then have non-resilient attachments. This is where there's no movement between the abutment and implant. So when that denture goes in there, it's somewhat fixated to that abutment or that attachment. The implant is going to receive 100% of the chewing force. So we're not going to rely on that patient's soft tissue to help support it there. Most commonly, it's going to be a bar overdenture or a kind of over-engineered prosthesis here. So if we look at kind of our resilient attachments, they're going to be our locators, O-rings, hater clips. Those are going to be attachments that are made for the actual attachment to move within the prosthesis. That prosthesis is going to move towards the patient's soft tissue. So we're going to utilize the soft tissue and the implant to retain that restoration. If we look at our non-resilient attachments, those are going to be our bar supported overdentures. If we have enough implants, enough AP spread, our conus type of attachments here, where that prosthesis goes in and that implant attachment are going to retain that prosthesis 100%, where that prosthesis will not have any movement unless the attachments are worn out there. But that implant's going to receive 100% of the chewing force when being utilized. We then have our the movement of the overdenture. So attachment movement does not equal prosthesis movement. So even though there is resiliency with a locator, the locator is going to move in 6 different ways as it pivots around the gold abutment there. However, that does not mean that that prosthesis is going to move 6 different ways. So the force is going to be transferred to the soft tissue. However, that doesn't mean the prosthesis is actually going to be moving there. So the importance of this is, especially if we have just implants in the anterior segment or a 2-implant overdenture, that patient's going to need relines frequently, especially in the posterior there. So as that patient wears that prosthesis and the soft tissue recedes, there's going to be a little space in the back there. So it's going to lead to overwearing of the attachments and much more frequent visits for that patient there. So just because the attachment has resiliency and moves does not mean that that prosthesis should move. If the prosthesis is moving, we should be changing the attachment, increasing the retention if needed, or looking at doing a potential reline of the prosthesis. And then last, and probably the most important principle here, is implant assisted versus implant supported. If we look at our primary stress bearing areas, so if you go back to conventional dentures back in dental school, we talked about primary and stress bearing areas with complete dentures. On the maxilla, that's going to be the hard palate. On the mandible, that's going to be the buccal shelf. This is the area that's not really going to resorb over time there. We're not really going to have any changes on that hard palate there. So if we're creating a prosthesis that has that hard palate in there, we're going to be using our implants, but we're also going to be relying on the soft tissue to support it. Similarly with the buccal shelf there. And that leads us into our implant removable classifications. This goes back to Mish in the late 80s here, where he termed two different type of overdentures as an RP4 prosthesis and an RP5 prosthesis. An RP4 prosthesis is a removable overdenture that is implant supported and implant retained. This is a prosthesis where we're relying solely on the implants to retain that prosthesis. So most commonly, this is going to be a maxillary overdenture without the palate. So we're relying on those implants to retain that restoration. On the bottom, this is going to be something where we don't have really flanges, no buccal shelf, where we are relying on those implants to retain that restoration. We then have our RP5 prosthesis. This is going to be an implant supported overdenture as well as a soft tissue supported overdenture. So this is going to be an overdenture with the palate included and the flanges and buccal shelf. So whenever that patient's functioning with an RP5 prosthesis, forces are being transferred to the palate. They're being transferred to the ridge as well as the implants there. So we're utilizing those primary stress bearing areas as well as the implants to retain the prosthesis. So if we go into the implant-based categories here and presenting them to patients, RP5, again, that's going to be our implant and soft tissue supported overdenture. So advantages of this treatment is it's going to be a removable prosthesis that clips in. So it's going to be much better than your conventional denture. You're going to have increased chewing efficiency. You're going to be able to bite more, more retention, more function, very easy to clean and maintain compared with a fixed prosthesis. So you're going to get a lot of advantages over a conventional denture. If we look at some of the disadvantages or what that patient must be aware of before undergoing treatment, is it's still removable. So if you come in with a conventional denture, our removable RP5 overdenture is still going to be removable. You're still going to take it out at night. You're going to clean the soft tissues. You do have to clean those implant attachments. You're going to do that every night. The clips need to be changed on a regular basis. This must be relayed to the patient when doing overdentures, that over time, those locator inserts, those O-rings, they need to be changed over time and they have to pay for it. These locator inserts cost a lot of money, and you will have to change them over time. So you don't want to be eating that cost. So I put that in my treatment plan and consent, where we did need to change these over time. Most commonly, it's every 4 to 6 months. Some patients, it's going to be sooner there, but you do have to pay for these attachments when they are changed. The denture may rock. So specifically, if we're making a 2 implant overdenture, I use the example of a 2-legged chair. That's rocks in the anterior posterior direction there. So patients must be aware of what these RP5 prosthetics, depending on where the implants are, that they are going to require relines every couple years there. So as you continuously change out the clips and attachments, you're also going to be evaluating them for potential relines. Eat as if you have a traditional denture. So an RP5 is still a denture. It has all the stress bearing areas, and similar with the denture where you kind of have to chew on both sides, you're going to have to do that with your RP5 prosthesis. So you're not going to be able to bite something in the anterior. Generally, depending on where your implants are in the AP spread, you're going to get some disengagement of those implants there. So explain that to patients where, yes, you will get more function out of these, but it's still going to be eating like you have a denture. And there is going to be palatal coverage. So this is probably the biggest thing to relay to the patient, where if we're going with an RP5 prosthesis, where you can only afford X number of implants, or your bone kind of dictates us where we can only place them in the anterior segment, we do have to cover the palate with that prosthesis. So again, the RP5 is going to be soft tissue and implant supported. It's going to cover those primary stress bearing areas. On the maxilla, that's going to be our hard palate. On the mandible, that's going to be the buccal shelf there. And next we have our RP4 implant overdenture. So this is going to be solely implant retained, where we're not relying on the soft tissue. Advantages: it's going to be a removable prosthesis, clips in, much more retention function than a conventional denture, more function retention than our RP5 prosthesis. Hygiene maintenance: it's going to be easier than a fixed prosthesis, and we have no palatal coverage. So for patients where we are able to put enough implants in, get enough AP spread, have enough restorative space, we're able to remove the palate in that prosthesis. Some of the disadvantages of the RP4: again, it's still removable. So if that patient's paying for that bar implant supported overdenture, they still must be aware that this is a removable prosthesis that they're to remove at night. The clips need to be changed on a regular basis. Generally, with an RP4 prosthesis, we have more implants, especially if it's a bar supported overdenture. You're not going to have to change the attachments as frequently, but they still do require their maintenance to change the attachments. And this is just showing two examples here of a of RP4 prosthetics that I delivered here. The top is a Bredent bar, where the bar is solely taking the force of that implant restoration, and then the bottom is a conus attachment. So this is a non-resilient overdenture attachment there. You can just see from the PIP paste where I'm not really having any pressure towards the soft tissue. I'm relying on those implant abutments to help support that prosthesis here. And then our next treatment option is going to be our fixed prosthesis, our all-on-X prosthesis. Advantages of this is it's a fixed prosthesis. So this is going to be the only prosthesis that the patient's not going to be able to remove, where they have to come see us as the dentist to remove. It's going to be most like their natural teeth, where they're not having to take their teeth out at night, put it in a glass of water. They're going to have the greatest chewing ability, the greatest chewing efficiency. They're going to have the best function, as opposed to our conventional prosthetics and our implant overdenture. Things that the patients must be aware of. Depending on the situation, pink acrylic may need to be added due to the bone loss or alveoplasty that needs to be performed to create the necessary restorative space. Not all patients, when they get these fixed prosthetics, are going to just get the tooth. A lot of them are going to have the artificial gingiva on there in between the implants. Food impaction. So similarly to patients that get 3-unit bridges, they are going to have food that gets underneath those prosthetics. It's our job as a dentist to make the prosthesis cleansable and instruct that patient how to clean the entirety of the prosthesis, but they are going to get food impacted underneath these fixed prosthetics. Hygiene is critical. So I mentioned earlier that some patients come in, they want the all-on-X, and they never want to go to the dentist again. They actually need to see us more frequently than conventional patients. The ACP has what they call a 4-3-2 maintenance visit, where in the first year, the patient should see us 4 times, second year, 3 times, third year, 2 times, where we're evaluating the prosthesis, making sure the patient's able to cleanse it properly, and re-emphasizing the importance of hygiene there. So hygiene is very critical with these fixed prosthetics. Adaptation period to speech. This is a very big complication that we'll highlight in a couple slides here, but your implant fixed prosthetic is going to be different than your conventional teeth there. So there is going to be an adaptation to speech depending on where the implants are emerging, that you will have to get accustomed to. And then it's going to be thicker than your natural teeth. So this is something that you also have to educate the patient that, especially if they've gone through bone loss or depending on where the implants are going to be emerging there. But generally, our fixed prosthetics are going to be thicker in the buccal-lingual dimension than their natural dentition here. And they must wear a night guard. Every patient that gets a fixed prosthesis must get a night guard to protect, due to the lack of proprioception there. So if we go to the MISH protocol from the late 80s here, this is the 3 different prosthetics that you will see in the literature. FP1 is going to be just the tooth. So this is where we are just replacing the normal tooth. This is a case where the patient really hasn't lost any bone, hasn't lost any soft tissue. We're able to do immediate implants and kind of preserve all the papilla there. It's going to be difficult to achieve a result like this, but this is what a lot of patients think that they may be getting, where we need to educate them that they may not be a candidate to get an FP1 prosthesis. We then have our FP2 prosthesis. This is going to be a prosthesis where it is solely tooth colored, similar to the FP1. However, the teeth are going to appear longer than the normal length here. So this is going to be somebody that may have lost some bone there. We don't need to add the artificial gingiva on there. Just the teeth are going to appear longer, but they're the same white. And then we have our FP3 prosthesis, which is going to be the most common that you will see. This is going to be a fixed prosthesis that is also replacing the gingiva here. So we're going to have some artificial pink colored gingiva that will replace the soft tissue as well as the tooth structure for it. So with it, we must educate the patient. So prior to undergoing treatment, we must explain to them that they may be a patient where we do have to utilize this artificial pink coloring for the gingiva. It's a very good idea to show them examples. So if you have a model. I know Glide will make some great models that you can buy from them, but let the patient hold it in their hands so they're able to see, okay, so I'm getting the teeth and the pink, because some patients may still look at this like it's a denture. So we do need to educate them that these prosthetics, the majority of the time, do have pink gingiva on them. Adaptation to speech, I think this is probably one of the biggest complications with these full arch implant restorations, specifically. Um, Depending on how long they've been edentulous, especially on the lower there. We know that over time that tongue will grow laterally, especially if they're not wearing a prosthesis. So it's going to take a adaptation period to get used to having those posterior teeth, to getting used to the contours of that restoration there. So that case on the right is a PMMA that I inserted and then I had to adjust several times to make that patient happy there. But when the implants are already in, we're kind of dictated by where the screw channels are and where the teeth are there. So we only have so much room with it. And if we look at the literature, there are many good studies out there highlighting these speech complications. This is a study here that found 87% of patients undergoing all-on-X treatment had initial pronunciation problems. So that's a pretty alarming statistic. And then this one here is even more alarming. We're at 6 years. 84% of patients still had difficulty with speech. So this is something that I kind of scare patients into it where, yeah, we'll give you the fixed prosthesis, but you're going to be talking differently for a fair amount of time there. You will adapt, but it takes everybody different here. So this study here, 6 years, 84% still had speech problems. So that's a very high number with it here. Another complication to be aware of is the contours of these prosthetics. So you must avoid concave prosthetics. You can see on the left there that it's a concave prosthesis. The patient has no way of cleaning underneath that area right there. So our prosthetics must be convex. They must be ovate to allow the patient to adequately cleanse under there. Properly with the water pick, floss thread, or whatever they're using, but making it an ideal contour will help immensely with it. And then on cases that I do the all-on-X immediate load, I have a specific section for that where I just highlight two things. One is they're limited to a soft diet during the healing phase. So just because you're getting the fixed prosthesis that day, you must eat like you have dentures for the 4 to 6 months. And I'll actually give them even a list of foods that they should be eating: fish, pasta. You don't want them eating steak. You don't want them eating corn, apples. And then the other caveat is if we're not able to get implants with great stability, great ISQ score, they may leave that day in a denture. It's good to have that in writing. So if you do put implants in and you're just not happy with the torque values or the primary stability, leave them buried, give them a denture. But it's good to at least explain that to the patient before undergoing treatment there. And we've seen so many issues with our institute, and clinicians having difficulty with patients with all-on-X. So my father put together a specific consent form. It's underneath that publication and forms tab on our website. So I highly instruct, if you are going to be doing all-on-X therapy, look at this consent form, give it to patients prior to undergoing treatment. It goes through all of these issues with this speech, maintenance, all this, just explaining it to them before undergoing treatment. So that's another free thing that you can get on the website there. Concluding our treatment planning here, treatment planning is not one size fit all. So the treatment plan should be tailored to each individual patient. So we'll give the patient each treatment option, and then it's our goal or our job as dentists to explain the advantages and disadvantages of each treatment option. We're supposed to inform the patient of all options, and I like allowing the patient to make an educated decision. So I don't like selling cases where, you know, you need to do this or you're going to die. Ultimately, we don't have to treat any patient. So give the patient all the treatment options, give them the advantages and disadvantages, and let the patient make the best decision for them with all the information you give them. Now, lastly, we're just going to cover the restorative space. Ultimately, these implant restorations are prosthetically driven with the prosthesis in mind. We have many complications when we have cases with inadequate restorative space with the prosthetics breaking, debonding, just very bad failures. Our goal is to determine the space preoperatively, not postoperatively. If we look at how much space we need, the numbers are all over the place in the literature. Um, we've kind of done the down here where we have two different guidelines that we look at. One is going to be our prosthetic space, which is going to be the measurement of the tissue to the occlusal plane. The second is going to be our restorative space, which is going to be measured from the bone to the occlusal plane. We're going to look at both of these spaces after determining our prosthesis to plan our implants. If we look at the space needed, there's many variables that we must take into consideration, whether it's a fixed or removable prosthesis, the material, the attachment type, and the anterior and posterior. Ultimately, we have different height requirements in the anterior and posterior depending on the tooth we're replacing. So if we look at our fixed restoration, zirconia or monolithic zirconia is going to be our most common. Restorative space, we need 10 to 12 millimeters. Prosthesis space, 10 millimeters in the anterior, posterior 8 millimeters. So these are kind of the guideline numbers that we must be aware of when planning these prosthetics to ensure that we have enough space. Again, we view it differently in the anterior and posterior. Our maxillary incisor is generally going to be a lot longer than our first molar. So different space requirements depending on where we are in the mouth. Then we have our removable prosthetic guidelines here. One thing that we stress is this is taken from Zest website, the locator. They say that you can get away with 8 millimeters for it, but we've kind of debunked this because they're not taking into consideration a denture tooth with their number. So don't listen to them when they say 8 millimeters. In actuality, you need a lot more room. So we've adjusted the numbers where we added a denture tooth onto it, as well as increased some of the numbers to make it more reasonable with such as the biologic width, allowing adequate movement of our prosthesis. But we actually need about 12 to 16 millimeters of restorative space. So we do need a lot more space than what some of the manufacturers do claim with their numbers. So locator prosthetic space, 8 to 10 millimeters. Restorative space, we need about 12 to 16 millimeters from the bone or level of the implant to the incisal edge or occlusal surface there. And then ultimately our bar supported overdentures are going to require a little more room. Locator is probably going to be the most common. This is an attachment that I really like using. It's a Bredent. It's actually an offset attachment. So it's not made on top of the bar, it's made on the side of the bar there. So you can get away with a little less restorative space, anywhere from 13 to 17 millimeters there. So take these numbers with you to practice when planning these cases to ensure that you have enough restorative space on these cases. To conclude, for this presentation here, again, a edentulous treatment is not one size fits all. Can't stress that enough. We must give the patient each available treatment option, advantages and disadvantages of each treatment, and let them make an informed decision. And then ultimately, our our treatment planning, our implant-based restoration must be prosthetically driven. So take those numbers from the restorative space to ensure that we have enough space for the prosthetic prior to undergoing treatment with it there. So we covered a lot throughout the webinar, as always. So thank you again, everybody, for the patience. And then I'll turn it over to you, Dr. Park.
Thank you, Chris. That was a great lecture, a tremendous overview. We appreciate it. And I've got a bunch of questions. Hopefully, you can hang around for a few more
Yeah,
minutes
yeah,
and
absolutely.
answer some
Yeah.
questions. Okay. So, when we hear there's so much conversation about all on X, and all on X, in my experience, is typically an FP3. And we see a lot less FP1s. But I was recently at the AAID, and there were a lot of doctors showing FP1 cases, and the reason is that they conserve bone, right? You don't have to whack away all that bone in order to hide the transition line. So the question is, what are the key requirements to achieve a successful FP1? Like you talked about something where they've just lost their teeth, right? They haven't lost a lot of bone and soft tissue. Can you kind
Yes.
of go over that?
Yeah, yeah. So the biggest thing with an FP1 is generally to achieve an FP1, you're going to be taking out the patient's teeth the same day as placing the implants because you have to preserve the papilla. So being able to preserve the soft tissue that was present with their natural dentition is of importance. Um, Ideal implant location. So to achieve those Pontic sites, those implants have to be emerging exactly where that tooth needs to be. So a lot of times with an FP3 prosthesis, we're able to, in essence, create a denture setup and then connect it to the implants. With an FP1 prosthesis, we need those implants coming out exactly where those canines are, exactly through the site of those molars there. So ensuring that they have adequate bone where those ideal implant sites are is of utmost importance, the soft tissue profile. And then I think probably at the AID, a lot of those presenters were talking about the digital workflow because that's really what has allowed us to achieve these FP1 prosthetics predictably is through the digital workflow. So taking our facial scanning, doing our photogrammetry conversion or our grammetry conversion, we'll call it, digitally designing it on exocad and printing a prosthesis, it's a lot. That's really the best way to do it. Whereas with our FP3 prosthesis, we're used to taking a denture and converting it to the prosthesis. So you're not going to really be able to take a denture and make it an FP1 prosthesis. This is something that's going to be designed kind of the same day based on our treatment planning.
Right, right. I had a question here. Well, is it possible to take an FP3 and convert it to an FP1? Well, I mean, my understanding is, yeah, you could, but you would have 22 millimeter long teeth. It would be,
Yeah,
yeah,
so it would be more like an FP2 prosthesis. So a lot of times especially on the mandible, I'll just make it an FP2 prosthesis because you don't really need the patient's not going to show the soft tissue down there. So
right.
you can
But
make the
like
teeth
an
more.
FP1, you don't necessarily have to hide the transition line, right? Whereas a,
No,
a two or a three, you have to.
correct. Yes,
Okay.
correct.
Got it. Got it. Okay. Um, what considerations do we need to take into account when dealing with an implant overdenture patient that is a bruxer?
Yes, so they're going to wear the attachments more frequently. They're also going to wear the denture. So at the end of the day, our implant over denture, the best material is still our denture. We're able to utilize milled CAD/CAM milled dentures, which wear a lot less than our conventional Avocar. However, they're going to wear through those dentures.
Or get printed dentures and order a box of them.
Exactly. So I actually had to do a case in residency where the patient was wearing through these dentures so frequently, we made a metal occlusal in the posterior. So, I mean, that's thinking outside the box. That's a residency case, but the wear of the attachment and the denture teeth.
Got it. Got it. Question about changing the screws. I mean, do you have to put new screws in every time you remove the prosthesis? Let's say if you're doing a really thorough hygiene visit.
Absolutely. So anytime you torque a screw in, it undergoes preload. So whenever you remove that screw, you're never going to achieve that same torque value there. So that is absolutely 100%. You have to when you remove the screw, you have to put a new screw in. And going to removing the prosthetics, the ACP has a position where as long as you make it cleansable and the patient has adequate hygiene, you're to not remove the prosthesis. So we're generally teaching that you don't remove those prosthetics at each hygiene visit unless necessary. And when you remove it, you're going to make the prosthesis cleansable so you don't have to continuously take them out there. So, but yes, absolutely change the screws.
Okay. Um, for all on X, what's your preference? Do you like to place the restoration the same day, or do you like to bring them back and put it in another day?
I generally like to do it the same day because the patient's already numb. I sedate a lot of my patients, so having them come back the next day or 2 days later, they're going to be sore, groggy. Sometimes you have to anesthetize them again. But depending on the case, I do like to put them in the same day.
Yeah. Okay. And you mentioned that you put your patients in a night guard. Is that only after you deliver the final prosthesis, or do you put them in night guard right away?
I have had cases where if I do like the all on X conversion, I will put them in a night guard for the 4 to 6 months, especially if they have severe parafunction. But generally, it's going to be after I deliver that final
Right.
Bruxer prosthesis. So generally,
Yeah,
after I
Chris, I'm a
deliver the
little
final,
afraid of them pulling on the
exactly,
night guard to
yeah,
remove it and pulling
exactly,
my
exactly,
prosthesis out.
yeah.
Okay. Let's see. Sleep, breathing. Okay, so a lot of times there's a suggestion to leave the dentures in at night if the patient has a breathing issue. What is your thought about that?
Yeah, patients that have to leave it in at night, I'll make them a duplicate overdenture. Generally, it's going to be a monolithic denture, so you can make it out of night guard resin, or I won't make it the exact same as their original one, but I'll make them a nighttime overdenture. So it'll be something they put in there, but it's not going to be a functioning one. It'll be a clear overdenture where they can utilize it at night there. So that's how I handle those cases.
Okay, and what about if the patient's on CPAP? Are you able to have the night guard along with the prosthesis in there? It seems like a lot of a lot of
Yeah,
hardware.
unfortunately, that's where it gets a little clunky there. So, certain cases you are, it depends on their CPAP machine, but it's patient specific.
Got it. Got it. Well, I think you did a great job with those questions. That was kind of a lot of quick lightning round, but it
Yeah,
was a great lecture. We're going to have you back. Maybe we'll go into a little more detail. We'll dive into the FP1s, the FP2s, the FP3s,
yeah,
and go from there, and maybe look at a couple different
yeah,
styles of overdentures.
yeah.
The uh, the 4 and the 5. So this was excellent. Thank you very much, Chris. It's
Thank you.
always a pleasure to have you here, and thanks to our panel. And we'll see everybody. Are we back next week, Nicole?
Next week
No,
is Thanksgiving, so happy
Thanksgiving. Okay.
Thanksgiving,
The
everyone.
week
We'll see.
after. All right. We'll see
Yep.
you in 2 weeks.